Hello, welcome back again to our virtual channel, which we will be discussing the next topic of oxygenation. Uh, Basically, as we all know that oxygen is the basic need of one human being. Okay, so as nursing assistants, very important how we'll tackle this lesson because it is very vital to our patients' lives. So let's start. So before we will start, we'll just define different terms that relates or are related to our oxygenation. So first, let's define what is hypoxia. Hypoxia means that the cell do not have enough oxygen. Okay. Next is tachypnea. We already discussed this. It is rapid breathing more than 20 or per minute, 20 cycles per minute or 20 breaths per minute. On the other hand, bradypnea, it is a slow breathing which is fewer than 12 cycles per minute. Apnea, A means absent, so it is lack of or absence of breathing. Hypoventilation, it is a respiration which is slow, shallow, and sometimes irregular. So, very slow respiration and irregular. However, hyperventilation, it is rapid and deeper. So that is hyperventilation. Dyspnea, if you saw a DYS in the beginning of the medical term, it refers to difficulty. So it is a difficult, labored, painful breathing. What is cane strokes? Okay, cane strokes respirations. It is a type of respiration which is gradually increased in rate and depth. Then they become shallow and slow, so it is irregular. Breathing may stop for 10 to 20 seconds. Orthopnea, however, is breathing deeply and comfortably only when sitting. So most of the patient, like COVID patient, okay, they are very comfortable in sleeping using this orthopnic position because they can breathe well when they are sitting. Cosmos respiration, this is very deep and rapid respirations. Cosmos respiration is very deep and rapid respirations. We have different ways in meeting our oxygen needs, and we will see or we will encounter this in the hospital or healthcare setting. So first is positioning. Positioning, it is the breathing which is usually easier in semi-Fowler's and Fowler's position. So always if you have patient with difficulty of breathing, we always position the patient into Fowler's or high Fowler's position because in that way the patient lungs will expand more. Another studies nowadays for those patients who are with COVID, okay, with COVID, they are proning the patient, okay? Proning position is lying on your chest, okay? So those studies discovered that this patient can uh, breathe well in this position, but they should turn every now and then, not only proning. After that is side lying, then after that is Fowler's position. This is very, very effective for those COVID patients. And uh, I, I, I saw that. So next is deep breathing exercises. Deep breathing exercises, guys, is you inhale in your nose and you release the air in your mouth. Okay, so moving air into most parts of the lungs. In this way, you will expand your lungs. You will prevent atelectasis. What is it? Atelectasis. It is lung collapse. Coughing. Coughing will remove your mucus. Okay, so after operation, you should advise your patient, okay, your independent intervention to deep breathe and to always cough. But when coughing, they should place a pillow, okay, on their abdomen, so it will not be painful. So this is an effective way, okay, to prevent atelectasis. They should do this every 2 hours while the person is awake. And pulse oximeter. So pulse oximeter measures your oxygen saturation. The normal oxygen saturation, as we all know, is 95 to 100%. Another ways to meet oxygen needs is oxygen therapy. So we have different ways or different devices for oxygen therapy. We have nasal cannula, we have simple face mask. Sometimes we are calling nasal cannula as nasal prong. We have also partial rebreather mask, we have non-rebreather mask, and we have venturi mask. You should familiarize yourself with this device because you're not putting this one unless your uh, hospital allows you or the nurse allows you or you have training. But the nurse will always ask you, can you give me nasal cannula? Can you give me this oxygen devices? So you should familiarize yourself. So how it looks like. So your nasal cannula or nasal prong, it looks like this figure 336.18. So this is how nasal cannula looks like. Okay, 36.9 also. If the patient, this is very efficient if the patient is eating by himself, so he can eat, okay, but with oxygen. Next is the simple face mask. Simple face mask. The simple face mask will cover the nose and the mouth. Then partial rebreather mask. This is the one with the bag. If you notice, there is a bag. Okay, there is a face mask and then there's a bag. And we have also non-rebreather masks. And we have also venturi mask. Okay, venturi mask, it is more accurate among all this oxygen device because it will deliver an accurate oxygen by using these colorful uh, devices. Okay, so let's define them one by one. So what is nasal cannula? It is a prong which is inserted into the nostrils. A band goes behind the ears and under the chin to keep the device in place. So we are putting it in the nasal prong, then in your ears, okay? Then in your ears, then on your chin, okay? There are some possibility that the patient might have a pressure related device. Okay, why? Because you are putting pressure on the back of the ear and on the chin, usual or on the back of the head. So what will happen if the patient is having this type of device? Maybe the patient might have a pressure ulcer. So you should put something like gauze or any other soft material so to prevent pressure ulcer. Then cannula allows eating and drinking. Okay, as I've told you, then tight prongs can irritate the nose. Pressure on the ears and cheeks is possible. Next, simple face mask. Simple face mask, it covers the nose and mouth, and a mask has small holes in the side to uh, escape the carbon dioxide when you're exhaling. Then partial rebreather mask, it is a bag. The bag is added to the simple face mask. The bag is for exhaled air. Okay, when breathing in, the person inhales oxygen and some exhaled air. Some room air also is inhaled. Then the bag should not totally deflate when inhaling. On the other hand, non-rebreather mask, it exhaled the air and room temperature cannot enter the bag. Okay? In the partial rebreather mask, the air can enter the bag, but in non-rebreather mask, the air cannot enter the bag. Exhaled air leaves through a hole. There is a hole in the mask. When inhaling, only oxygen from the bag is inhaled. The bag must not totally collapse during inhalation. Lastly, when to remask, it is a precise, as I've told you, the accurate amount of oxygen are given because there is color-coded adapters show the amount of oxygen given. That color-coded adapters, it has a number like 2. It means that 2 liters of oxygen you are putting on the patient. So it will deliver an accurate amount of oxygen. Next, it will sometimes tell you 10 liters of oxygen. So it is the most accurate ways of giving oxygen. Okay, so these are the pictures of oxygen devices. So oxygen flow rates. What if you discovered a patient, okay, with oxygen who has an oxygen rate which is lower than the required? Okay, are you allowed to are you allowed to regulate it? Normally you're not allowed to do that, okay, because only the nurse is the one who can do that. But if you have training for oxygen therapy, you can do that. So when giving care and checking the person, always check the flow rate. Tell the nurse at once if it's too high or low. A nurse or respiratory therapist will adjust the flow rate. But there are some instances like emergency situation that you saw a patient, for example, difficulty breathing, and you saw that the oxygen, okay, of the patient is oxygen saturation is decreasing. The nurse is not there because she's taking care of the patient. So as your response, you can put the oxygen for your patient, but in a lower rate only, like 2 or 3. Okay, but don't exceed on that because the the main responsibility or the main person who can has the responsibility to regulate the oxygen is your nurse. But there's no nurse, there's an emergency, so you should initiate something so to save the patient's life. You do not give oxygen. You assist the nurse in providing care. Normally, it's like this. Always check the oxygen level when you are with an or near person's using oxygen system that contain a limited amount of oxygen. Usually, COPD patient, guys, okay, remember this. COPD patients, they only have a lesser oxygen rate. Okay, what do you mean by that? Only 2 liters per minute is the maximum. Why? Because they have this oxygen drive, we are calling it as oxygen drive, that if you regulate the oxygen higher than 2, okay, they will be having difficulty breathing. So for COPD patients like chronic bronchitis and emphysema, okay, you should put only until 2 liters per minute. Then follow the rules for fire and use of oxygen. Of course, if your patient is smoking, don't tell him that if don't smoke in the hospital because we have almost all the beds have installed oxygen on the bedside. Then never remove the oxygen device. Make sure the oxygen device is secure but not tight. Okay, if your patient is connected to an oxygen, okay, and that oxygen is connected to the bedside, okay, and your patient wants to go to washroom, okay, get a portable oxygen and connect the oxygen device to the portable oxygen, because there's a tendency that the patient might have difficulty of breathing during walking or during going to washroom. Check for signs of irritation from the oxygen device. Okay, as I've told you, you can put pressure when you're putting an oxygen device. So make sure to prevent this pressure ulcer. Keep the face clean and dry when a mask is used. Okay, the tendency when you're putting a mask or face mask or any non-rebreather or partial rebreather mask, what it will do, it will make your mouth dry. So always tell the patient to gargle water. Never shut off the oxygen flow. Do not adjust the flow rate unless allowed by your state and agency. Tell the nurse at once if the flow rate is too high or too low. Tell the nurse at once if the humidifier is not bubbling. What is the humidifier? Humidifier is the one bubbling, the one with water. So if it's already uh, consumed, you need to replace it. Okay, there are some commercially made or ready-made humidifier that you can attach to the oxygen. So you will have training on how to do that. Secure tubing to the person's garment. Follow the agency protocol. Make sure there's no kinks in the tube because the oxygen will not pass through the tube if there is kinks. Make sure the person does not lie on any part of the tubing. Report signs of hypoxia, respiratory distress, or abnormal breathing at once. If you saw the patient, even the patient is having oxygen, like nasal cannula, and you saw the patient that is having respiratory distress, the oxygen saturation is still down, you need to report it immediately to the nurse because maybe that person needs another higher rate of oxygen or another oxygen device like Venturi mask or partial rebreather mask or non-rebreather mask. Make sure to give an oral hygiene because as I've told you, if your patient is receiving an oxygen, it will make the mouth and the nose dry. So always offer the patient an oral hygiene. Make sure the oxygen device is always clean and free of mucus because some patients, okay, they have too much mucus or phlegm. So it might be accumulated on the oxygen device. So you need to always clean this. Next, another ways to meet oxygen needs is incentive spirometry. So incentive spirometry, the machine that measures the amount of air inhaled. Okay, so incentive spirometry, if you see like this is called incentive spirometry. Incentive spirometry is very helpful for those patients who is post-operative because it will expand the lungs. Because if you are operated and you receive anesthesia, the tendency is it will collapse your lungs. So to expand your lungs again, you need an incentive spirometry or spirometer. So how to use this? The spirometer is placed on upright position. The person exhales. Normally, he or she seals the lips on the mouthpiece and a slow, deep breath is taken until the ball rises to the desired height. So you will see a ball here, the yellow one, it should be increased, okay? So it should be increased slowly by slowly as long as you are doing this. So it means that your lungs is expanding. The breath is held for 3 to 6 seconds to keep the balls floating. The person removes the mouthpiece and exhales slowly. A person may cough at time. After some normal breaths, the device is used again. So this is the incentive spirometer. Next, how we are collecting sputum samples. Okay, as nursing assistant, this is also one of our responsibility. If your nurse told you, can you collect sputum samples? Because we have one patient, need to check for any infection in the sputum. So what is sputum first? Sputum first is a mucus from a respiratory system. Okay, it's different from saliva, guys. Saliva is like, it's in your tongue, it's in your mouth. But sputum, it comes from deep, okay, from your throat. Okay, it is different from saliva. It is ideally collected early in the morning, and you need to collect it before you brush your teeth. You just rinse your mouth with only water, not mouthwash. You just rinse your mouth with water, and then you can collect it. Okay, so to collect a sputum specimen, you need this information from the nurse. When to collect the specimen, how much sputum is needed. Usually it is 1 to 2 teaspoons, so about 5 to 10 ml. So if the person uses the bathroom, if the person can hold the specimen container, What observations to report and record? The time the specimen was collected, so usually early in the morning, the amount of sputum, how easily the person raised the sputum. What's the color of sputum? Is it clear, white, yellow, green, brown, or red? So if it's clear, maybe it's only saliva. Okay, it should be color yellow, or it should not be clear. Sputum odor, if it there is it foul odor or odorless. Then sputum consistency, is it thick, watery, or frothy? Okay. Hemoptysis. What is hemoptysis? It is a bloody sputum. Sputum. So if you saw this, if you saw blood in a sputum, it means there is something. Maybe there's bleeding. Maybe there's an infection like tuberculosis. If the person was not able to produce sputum, okay, what they are doing, they are nebulizing the patient. Okay, it will help the patient to uh, collect sputum. Then, when to report observations, what patient or resident concerns to report at once. So this is how you collect, or what are the informations you need to have if you are collecting sputum specimens. Next, respiratory support and therapies. Okay, if you are assigned to a ICU or special care unit, okay, you will see a lot of artificial airways like mechanical ventilator. Okay, so what is artificial airways? It keeps the airway pattern, okay, open and unblocked. Okay, if the patient cannot able to breathe by himself, they are putting a device like a mechanical ventilator so that the patient can breathe artificially, okay, using that machine. What is intubation? Intubation, it means inserting an artificial airway. When inserting a tube so the patient can breathe, it is the process of intubation. So we have different uh, types of artificial airways we can see in the hospital. We have the oropharyngeal, we have the endotracheal, and we have the tracheostomy tube. Okay, if we're talking about oropharyngeal, okay, oropharyngeal, oro means oral. So they're putting from the mouth until to the pharynx. Then, when we're talking about endotracheal, okay, so they're putting to the mouth until to the trachea. So this one, endotracheal. Usually they're doing this one. So this is temporary. And the more permanent one, okay, this is the tracheostomy. Okay, on the lower part, they're putting a hole or incision by operation. They're putting a hole in the trachea so the patient can breathe. So next, what is TT, tracheostomy tube? Okay, we will be tackling the different parts of tracheostomy tube. Why? Because we are doing catheter tracheostomy care. We are cleaning the tracheostomy tube. Why? Because most of the patient, they have the sputum or they have mucus, like thick mucus that can accumulate on that tube. And if it will accumulate on the tube, it will block the airway. So we need to clean it regularly. So what are the parts of tracheostomy tube? The main part of tracheostomy tube is the outer cannula. So this is the outer cannula. So the outer cannula, the one visible to you. This is the inner cannula. We have the balloon. We have the cuff. Okay. We have the fenestration. We have the shaft. And we have the face plate. Actually, we have also other one, the obturator. Okay. So let's go with tracheostomy care. So tracheostomy care is very important to prevent the accumulation of mucus in the tracheostomy tube, to prevent the blockage of the airway. Okay, so what is the frequency of doing this tracheostomy care? So it should be daily or every 8 hours to 12 hours or PRN as needed. If it's so clogged, you need to do it even if you did it in the morning. Cleaning the inner cannula to remove the mucus and keep the airway pattern. So I'll show you how to do this. Nurse tells you what cleaning agent is needed. Okay, in some hospitals they are allowing you to do this. Okay, they will give you training and they will, and you can do this. And if you're assigned to a home, okay, like you are a home care nurse or caregiver, okay, you need to do this if your patient's having tracheostomy. So usually what they are using, before, hydrogen peroxide with normal saline or mild soap, but in our hospital we are only using normal saline, so it will not irritate uh, the trachea. Okay, cleaning the stoma is the one, okay, the opening, to prevent infection and skin breakdown. Applying a tie, okay, velcro collar to prevent infection. We have also, we need also to be familiar with suctioning. Okay, suctioning airway, we have different routes on suctioning our airway. Okay, what is suctioning first? Suctioning is process of withdrawing or sucking up fluid or secretions to prevent blockage of the airway. Okay, so most of the patients, especially if they are having infection on their lungs, they have a lot of secretions. So you need to withdraw that. So before doing suctioning, you need to hyperventilate the patient. You need to give 100% 100% oxygen to the patient, like you are ambu bagging the patient. So before suctioning. So we have different routes of suctioning patient. We have an oropharyngeal, we have a nasopharyngeal, and we have lower airway like ET and tracheostomy tube. So I'll show you the different pictures. So this is called oropharyngeal, okay, suctioning. So you're using a young cooler, okay? If you're familiar with our oral care, okay, for dependent patient, okay, we are using this one, oropharyngeal suctioning. We have also nasopharyngeal. So we are suctioning the nose because some mucus might be accumulated on this area. We have also lower airway. So this is are the most popular. We are using the ET, the endotracheal. Okay, sorry, the on the right one. This is the endotracheal, the right side of your monitor. Okay, then on the left side, that is tracheostomy tube. We are suctioning the tracheostomy tube. All of this I'll be demonstrating on Friday. So what are the safety measures of suctioning? Suctioning, it's not that easy because you need to consider some points, okay? First, review the procedure with the nurse. Know what you are to do. What you are to do. It should be with your job description. You should have training on doing this activity. Report coughing and signs of symptoms of respiratory distress. Normally, the patient will cough if you suction the patient. It means that because you are suctioning the trachea. So the tendency or defense mechanism of the trachea is you will cough. Okay, so don't be afraid. Don't be afraid if the patient cough because it's normal. It also a sign, coughing also is a sign for a need of suctioning. It means that there's a lot of secretions. Then suctioning is done as needed, not a schedule. It should be PRN. Follow standard precautions in bloodborne pathogens. Our suctioning is a sterile technique, so you should use a sterile gloves because it's inside, it's invasive. Any invasive technique, you should use a sterile gloves. We should always also consider that the nurse tells you that the catheter type and size needed. Okay, what catheter size? Because if it's big, is it small? If too large, it can injure the airway. Needed suction supplies and equipment are kept at the bedside. They are ready for the person needs suctioning. Okay, always it's in the person's bedside. So anytime the patient needs suctioning, okay, you can easily do the suctioning. Suctioning is not applied while inserting catheter into lower airway. When suction is applied, air is sucked out of the airway. Okay, what do you mean by that? If you're inserting the suction into the patient's trachea or airway, you should not put the suction. You will just insert it. But if you're removing the catheter, okay, or the tracheostomy catheter, then you put the suction. Okay, I'll repeat. If you're inserting the suction, don't press the suction. Don't put the suction. Okay, it should be put or applied when you're removing the catheter. Okay, and when putting suction, it should be intermittent. Okay, intermittent means it's not continuous, because when you're applying continuous suctioning, it will injure the airway. The catheter is inserted smoothly. This will help prevent injury to mucous membrane. A suction cycle for adults takes no more than 10 to 15 seconds. It means that one suction, it should take only for 10 to 15 seconds, not more than that, because the patient will hypoventilate. Okay, he will have hypoxia. He will not have oxygen. For infants and children, it should be no more than 5 seconds only. The catheter is cleared with sterile water or saline between suction cycles. So if you suction one cycle, okay, after that, you'll put it on a bottle of saline or sterile water to clear the secretions. Then you'll put it back again and suction the patient. The nurse waits for 30 to 60 seconds between each suction cycle. So usually we can do suction at that time, suctioning for that specific time for 3 times only, not more than that. Okay, so each suction you should wait, or the interval should be 30 to 60 seconds to give time to the patient to rest. Then it should be 3 times. And how far you will insert the catheter, it should be 4 to 6 inches only. So you will not hit the what's this you will not hit any or injured any airway or parts of the respiratory system. You should always check the vital signs of the patient when, before, and during the procedure, so you will know if the patient will tolerate or can tolerate the procedure. Then a decrease in pulse rate or pulse rate less than 60 beats per minute. Okay, so you should report it to the nurse. Irregular pulse rhythm, an increase or decrease in blood pressure, respiratory distress, a decrease in oxygen saturation. A normal range should be 95 to 100%. Next, we have mechanical ventilator or mechanical ventilation. Okay, mechanical ventilation, it is the machine which is attached to the endotracheal tube or tracheostomy tube or oropharyngeal tube. So this is a machine to move air into the lungs. It is like the artificial lungs. Okay, so we are not connected with this. We are not responsible to operate this. The one responsible for this is the respiratory therapist, because they are the one trained to do it. We have also chest tubes. Okay, chest tube is used, okay, if your patient is having air in the lungs, is it called pneumothorax? Okay, and if your patient is having blood in the lungs, which is called hemothorax. Okay, how the patient will get this? So, sometimes they'll get this from stab wound. Okay, if you are being stabbed, okay, especially in your chest, okay, and it will penetrate your lungs, so air will comes in into your lungs, and it's bad because normally the air in your lungs is in negative pressure. So if it's being stabbed, it will, if it will be stabbed, the positive pressure from the outside environment will go inside, and it will cause a deteriorating effect to your patient. So they need a chest tube just to remove this air or blood. So this ends my discussion on oxygenation. So if you have question, guys, you can ask me in in our WhatsApp group. I hope you understood the topic, and you will understand it more if we will be demonstrating it on Friday. Thank you and bye-bye.